USMLE-style question on non-communicating obstructive hydrocephalus. Question. A 4-year-old boy is brought to the pediatrician due to progressive headaches, nausea, and vomiting over the past 2 weeks. His mother reports that he has become increasingly irritable and lethargic. On physical examination, his head circumference is above the 95th percentile for age, and he has bilateral papilledema. MRI of the brain reveals enlarged lateral and third ventricles with a normal-sized fourth ventricle. Which of the following is the most likely cause of this patient's condition? A. Decreased CSF absorption at the arachnoid granulations. B. Increased CSF production by a choroid plexus papilloma. C. Structural blockage of CSF outflow at the cerebral aqueduct. D. Chronic ischemic damage to the periventricular white matter. Atrophy of brain parenchyma leading to compensatory ventricular enlargement. Answer C. Structural blockage of CSF outflow at the cerebral aqueduct. Explanation. This patient presents with non-communicating obstructive hydrocephalus, which is characterized by increased intracranial pressure, ICP, headaches, nausea, vomiting, papilledema, ventricular enlargement upstream of the blockage, selective ventricular dilation, e.g., enlarged lateral and third ventricles, but normal-sized fourth ventricle, suggesting aqueductal stenosis. Causes of obstructive hydrocephalus: aqueductal stenosis, most common cause in children; congenital narrowing of the cerebral aqueduct of Sylvius, preventing CSF from flowing from the third to the fourth ventricle; colloid cyst of the third ventricle, blocks the foramen of Monro, enlarges lateral ventricles; tumors, e.g., medulloblastoma, ependymoma, can compress the ventricular system. Imaging findings: ventriculomegaly upstream of obstruction, e.g., if the cerebral aqueduct is blocked, lateral and third ventricles enlarge, but the fourth ventricle remains normal. Treatment: surgical removal of obstruction, if due to a cyst or tumor; ventriculoperitoneal VP shunt to drain excess CSF. Why not the other options? A. Decreased CSF absorption at the arachnoid granulations, seen in communicating hydrocephalus, e.g., post-meningitis scarring or subarachnoid hemorrhage, which would cause symmetric enlargement of all ventricles, not selective dilation. B. Increased CSF production by a choroid plexus papilloma, rare cause of communicating hydrocephalus, usually seen in infants, would cause global ventriculomegaly, not selective ventricular dilation. D. Chronic ischemic damage to the periventricular white matter, seen in normal pressure hydrocephalus, NPH, which presents with the triad of gait disturbance, urinary incontinence, and cognitive impairment, not increased ICP. E. Atrophy of brain parenchyma leading to compensatory ventricular enlargement, seen in hydrocephalus ex vacuo, which occurs in neurodegenerative diseases, e.g., Alzheimer's, Huntington's. Unlike obstructive hydrocephalus, it does not cause increased ICP. Take-home point: obstructive, non-communicating hydrocephalus occurs due to a structural blockage of CSF flow within the ventricular system. It leads to selective ventricular enlargement upstream of the obstruction and symptoms of increased ICP, headaches, nausea, papilledema.